Overcrowded ERs are an all too common sight here in Canada.
Yes, you are right. It is worse than the local hockey team losing in Game 7 of the finals, and yes, it is worse than the riots that tore downtown Vancouver apart. The Canadian Association of Emergency Physicians is calling this issue a national epidemic in Canada, and it is the main cause of ER overcrowding. This campaign is calling out to the general public in British Columbia to form a collaborative voice with hopes that their voice reaches the attention of the provincial government, since they are responsible for the delivery of the health care services and they have the authority to allocate the fundings in the form of fiscal transfers. The public will acknowledge the existing problem and will understand the root causes of ER wait time in order to motivate them to bring about change. In the long run, the voice of the public will reach the provincial government and they will appropriately allocate the funds and resources to the ER and other levels of care, such as residential, community, and inpatient wards. Of the 14 million Canadians that visit the ER every year, 3% left without being seen. A third of the patients who require hospitalization wait more than 10 hours to be transferred to an appropriate inpatient bed. As the demand of emergency services continue to rise, the accessibility of emergent care decreases. Overcrowding, the principal cause of prolonged wait times, occurs when the demand for emergency services exceeds the ability of the staff to provide quality care within acceptable timeframes. The budget cuts caused a 40% decrease in hospital bed capacity, creating an impaired flow of patients from the ER to ICUs and inpatient wards.
We've seen major cuts in the last year to seniors programs, to surgeries, to addiction programs, to mental health programs.
Overcrowding rarely occurs when bed occupancy rates approach 85%. It begins to occur more consistently at rates greater than 90%. Unfortunately, most hospitals in Canada regularly operate at a bed occupancy rate of 95%. Almost 50% of the patients who visited the emergency were discharged within an average of 2 hours from registration, depending on the severity of presenting illnesses, patient's age, patient traffic, and time. Patients waited an average of 51 minutes from the time of admission to see a physician. Not only does a patient have to wait to access care, they also have to wait for continuing care. There is a correlation between ER wait time and the total length of hospitalization. After leaving the ER, patients who had waited longer for treatment also appeared to be hospitalized longer.
Objecting to the plans to cut 18 acute care beds and eliminate nursing jobs with it.
Funding cuts to long-term care is greatly associated with the lack of admitting beds in acute care wards, causing congestion in the ER. Shortages of long-term care beds have pushed back many non-acute patients from being transferred to an appropriate nursing facility, affecting the flow of patient transfer from the ER to acute care unit. The inability to transfer patients from the ER to inpatient beds results in boarding of the admitted patients in the ER for long time periods.
How routinely at hospitals, emergency room patients are shunted into corridors and other public spaces, stripping them of privacy and dignity.
The lack of admitting beds, either in an acute or long-term care setting, has definitely impacted the traffic in the ERs. Many non-emergency patients that are waiting to be transferred to the appropriate care units are occupying many beds that are needed for admitting new patients. The resources and funding that are distributed to the acute care units are also being used inefficiently for those who are using the acute ward as a transitional unit. If changes are made in one area of a medical service, there is a likelihood that other areas of the healthcare facilities could also be affected. If the flow of an acute care ward is being operated appropriately and efficiently, the recommended wait times in the ER, depending on the patient's condition, can also be maintained. The Canadian Triage and Acuity Scale is a tool that helps healthcare professionals provide efficient and timely patient care based on the level of acuity and diagnosis. The CTAS is not being utilized as desired because it is only being used in 80% of all Canadian ERs. The CTAS has proven to be effective. It has reduced wait times significantly in the UK, and almost all their patients spend less than 4 hours in the ER. It is an overwhelming situation that may create negative impacts on the patient's physical, emotional, and mental well-being, the number of patients leaving without being seen, and the risk of poor outcomes.
Care and compassion are being compromised.
ER overcrowding has created a barrier for healthcare providers to deliver quality care in a timely manner, causing patients to experience unnecessary prolonged pain. 27% of emergency room users felt that the care they received was either fair or poor. Patients being assessed and treated in the hallway inhibits the nurse's ability to perform thorough assessments and protect the public by maintaining privacy and confidentiality, as well as to preserving dignity.
Talking with a patient on a stretcher in the waiting room underneath the television screen about whether he wanted to be resuscitated.
Overcrowding has a serious negative impact on the level of stress among nurses, recruitment, and retention. Having to work in such an overwhelming environment can be physically and mentally draining, which makes it challenging for doctors and nurses to provide high quality of care in a timely manner. The CAEP has connections with provincial, national, and international organizations which assist in the coordination of activities and the exchange of information and ideas. Stay informed. Any updates and announcements on the ER overcrowding issue can be found on the CAEP website. You can also follow the CAEP on Twitter.